Our third physician is Dr. Timothy Quill, and we attempted to get physicians with different perspectives and who come from different backgrounds. He's professor of medicine, psychiatry, medical humanities, and a variety of other things at the University of Rochester.
So thank you for having me. I'm going to talk kind of fast because I have a fair amount of stuff I want to get through in my 12 minutes. And I'm really glad to be here and to talk about this. I practice in New York where the practice is not legal. I have no financial conflicts of interest, but I have been an advocate for open access to this practice for a long time. So I'm going to start out with two cases. 65-year-old African-American man, married a long time, very artistic but not spiritual or religious, diagnosed with ALS 2 years ago. Using assisted ventilation at night, he lost 100 pounds. And he wondered about his last resort options, and he asked me to come in to provide a second opinion. Second case, 85-year-old Caucasian woman, a widowed mother of one of our palliative care clinicians, retired teacher, feared being a burden to her 4 children. She had early Alzheimer's disease, diagnosed 18 months early. She stopped driving. She was still maintaining herself at home. She wanted desperately to die at home in her own bed before it was too late. So this is real world, and this is recent real world for me. So fundamental access to health care is the floor. So traditional state-of-the-science medical treatments, you want to make sure people are getting that. You want to make sure they're getting adequate palliative care, pain and symptom management, decision-making assistance, support, and sometimes assistance with end-of-life decision-making. And then hospice when they accept that they are dying. Hospice as a philosophy of care, but also as a medical benefit, and those may be two different things sometimes. So again, when we say 100% of suffering can be relieved with hospice, I think we frankly frighten people. I think they know it ain't so. So we have to learn how to acknowledge the exceptions. Sometimes the exceptions are uncontrolled physical symptoms, pain and shortness of breath. Sometimes it's psychosocial, existential, and spiritual suffering. The notion we would have 100% answers to these dimensions of suffering is really a little preposterous. And sometimes the dependency and side effects of some of the treatments we ask people to endure are outside of the realm for some people. And again, this is an older study. It's been cited earlier, but it ain't pain. Usually it's not pain in these circumstances, but it's a complex mix of psychosocial and physical suffering. It is not just psychic suffering, though. This is debility, having trouble eating, having trouble getting around. It's quite complex. So why are these last resort options important? A lot of people have actually seen kind of harsh deaths, and they wonder what would happen if that happens to me. So the possibility of an escape is really important to some people, and awareness of options is really important to some patients, families, and caregivers. So if you know what your options are, oftentimes you won't have to exercise them, but it gives you a sense of reassurance. So there's 2 times when these questions come up. This is a really common one, reassurance about the future. You know, who's going to help me if things get really bad in the future? This is a common worry that people have. I think I would be worried about this, and I have a lot of contacts with really good doctors. So what am I most afraid of? What might death look like? Those who know who will be their doctor through this process have a huge leg up in this process. They are then free to worry about other things, think about other things. But, and again, from some data from Susan Toll from Oregon, just to illustrate this, 1 in 6 talk to their families about that. Probably even more think about it themselves. They don't even dare bring it up to their families. But 1 in 50 talk to their doctors, and yet it only accounts for 1 in 300 deaths by physician-assisted deaths. So most people want to talk, they want to be listened to, but relatively few ultimately act in an open environment. But if we are going to make that commitment, we have to be ready for when people say they want help now. So this is a much smaller group, and when that happens, it should be the beginning of a conversation. Tell me why now. Tell me the worst part. Sometimes it's uncontrolled symptoms. Again, there's a differential diagnosis to it. They might have gotten depressed. They might be anxious, but it also might be uncontrolled, intolerable suffering. So we're going to, for these patients, try to make sure all palliative care alternatives have been looked at and exhausted, and we're going to look for the least harmful ways to respond that respect the values of the major participants, including me if I'm the doctor in this process, ensure patient-informed consent, and full participation of the close family. You don't have to have everybody involved, but the close folks. And here's a list of the options in sort of order of agreement about acceptability. So again, on the green, accelerating opioids to the point of sedation if needed. You know, most of the data about good pain management suggests it prolongs life rather than shortens it. But sometimes at the very end with severe pain or severe shortness of breath, you really do have to use high doses. And sometimes that might shorten life a little bit. It's not your intent usually. Life-sustaining therapy, again, there's a general agreement that you cannot start, or if you start it in one circumstance, they end up in another circumstance, you can stop it. And people can say they're ready to die in that circumstance. And our general rule is listen to them, right? If they're telling you that, if they're on life supports. Take away the life supports, maybe there's something wrong with them. Maybe they're mentally ill. Maybe they're too weak. Yellow area, I'm going to talk a little bit more of. These are some, I would say, gray area interventions, stopping eating and drinking, and palliative sedation. And then the two in the red have been talked about a lot, so I'm not going to talk about them in any depth in this talk. So what is voluntarily stopping eating and drinking? It's the result of an active patient's decision of somebody who's physically capable of eating and drinking. It requires tremendous discipline to do. It usually takes 1 to 2 weeks. It theoretically doesn't require a physician involvement, but it really does as part of the assessment and also to manage symptoms as you go through the process. The main symptoms, dry mouth and then delirium toward the very end. It's probably legal, although it's never been formally tested in the courts. And then palliative sedation, potentially to unconscious. You know, light levels of palliative sedation, that's not what we're talking about. We're not talking about a little bit of anxiety medicine to help people relax. This is when you're taking the risk of impairing consciousness to help people escape from suffering. So, and you might go all the way to unconsciousness. You might go all the way in one step sometimes because the suffering is so severe. Think of somebody bleeding out from a carotid artery or something like that. Use benzodiazepines or barbiturates. The process usually takes days to a week, and the patient usually dies of dehydration or some complication of the sedation. Patient is generally unaware of the suffering, we hope, right? Because they can't tell us anymore often if they're not able to report any longer. So you're going to continue any kind of pain medicine or other anxiety medicine while you're providing the sedation. From an ethical point of view, this is viewed as a combination of the double effect and withholding life-sustaining therapy. It's a legal option for patients who have capacity, but also those who have lost capacity. Its utilization varies hugely between sites, and this should be a sobering thought for you, because there are places, there are palliative care programs where almost everybody is sedated at the very end, and there are places that almost never provide sedation. And I will tell you that has nothing to do with patients. It has to do with doctors' values. So again, the same kinds of safeguards that we're thinking about and wringing our hands about physician aid in dying, we ought to be thinking more about for sedation, in my opinion. So options in states where it's legally prohibited. So what happens, I live in New York, it's legally prohibited in New York. There are organizations that support more end-of-life choices. And again, it'd be an open question whether somebody was interested in this. Do we put them in contact with these organizations, or do we withhold that information? And again, if there, I think that would depend, that would differ between us. I think we would differ on that issue. But there are these organizations, and this is, they're open to being contacted. And what do they provide? They provide information around legal and underground, what I call last resort options, those options that I had just shown. They provide sometimes counseling for those actively considering one of those options. They sometimes provide presence for those who are considering one of the last resort options, and presence is a really important thing, potentially. You hate to think about people dying alone because we're afraid to be with them because it's legally dangerous and feels legally dangerous. And then they also provide advocacy to expand and liberalize laws regulating these practices. So there is a need for safeguards to protect the vulnerable from error, abuse, and coercion. We want to ensure access to and adequacy of palliative care. We want to make sure requesters are aware of the full range of options open to them. In my opinion, the risks cited for physician-assisted death are also present to a greater or lesser degree for the other last resort options. Safeguards must find a balance between flexibility and accountability, privacy and oversight. You can make safeguards way too hard, so they add to the burden of this, and you could make them too easy. And the categories of safeguards: palliative care needs to be accessible and found to be ineffective or unwanted, rigorous informed consent, diagnostic and prognostic clarity, an independent second opinion, and then documentation and review. So advantages about being explicit about last resort options: it acknowledges the problem. Many people are going to be less afraid if they know what their options are. They then have energy freed up for much more important things than worrying about if anybody's going to be there for me if things get really bad. It reinforces physicians' imperative to be responsive, to not abandon patients, to get help if they get stuck and don't know what to do, to get somebody else involved. Being clear about what you can and cannot do to help is really important as a clinician. The laws tell you what is legal, but not necessarily what is ethical. You need to try to be as responsive as you can, but you should not violate fundamental personal principles regardless of the status of the law. So again, you have to think this through a little bit in advance. So going back to our cases, the case of the ALS patient, he was not clinically depressed. Up until very recently, he had been actively involved in his work. He enjoyed being with his wife and family. This exploration was consistent with long-standing personal values, and he was willing to accept a hospice referral to maximize palliative care. We then explored the last resort options available to him, the promise of aggressive symptom management when and if the time came, which he was appreciative of, the possibility of palliative sedation if needed, if he got into serious immediate suffering, which he was appreciative of, the possibility of stopping eating and drinking at a time of his own choosing, which he found kind of macabre because he loved to eat and he just couldn't imagine doing this at the end of his life. And then the possibility of physician-assisted death, which was his clear presence. So he's in the process of exploring the underground practice. And this is a work in progress, so I don't know where this is going to go. What about the patient with early Alzheimer's disease? I met with her and her family every 3 months over 9 months, initially thinking over options, wanting to make sure her children would be okay. I had separate meetings with her and then separate meetings with her and her family. She went back to see her dementia specialist to make sure she was still thinking clearly, which they felt she was clearly enough to make this decision. Making sure that she was doing this decision for her and not for her children, which was a tricky issue because it was probably for both, really. And the risk of acting prematurely versus waiting too long. She decided on a date. She had a final meeting with me to ensure she was certain about going forward, had a celebratory meal, arranged for 24-hour presence with family and professional caregivers so she was not alone. And she remained very disciplined and died 12 days after starting that in her own bed, in her own home, surrounded by her children. A couple of references and some websites if you don't know how to access these and you're interested. These are websites about advocacy organizations who give you information and give patients information about last resort options. Thank you.